Bismillahirrahmanirrahim. Let's see the cerebral palsy. Cerebral palsy is actually a static type of brain lesion which occur during the brain development. So, which if affect the movements and the posture. So, it's a brain lesion during the development of brain and if affect the motor system in movements and the posture. But the important thing is that it's a permanent in nature. I mean it's cannot be reversed. Only the life of the patient can be improved, but it's cannot be reversed, and it's not further progress. I mean it's not further worsen. Okay, so it's a permanent lesion of the brain, okay, which is static type, and it's occur in the during the development of brain. You can say it's a pediatric problem. And there are different types of the cerebral palsy. So according to area of lesion, so the cortex is involved. So the presentation is a spasticity, mean the upper motor neuron lesion, the muscle is paralyzed and the tone is high. So and the meniscus sign or the reflexes are the exaggerated. Okay, and if the lesion is in the basal ganglia, so there is athetosis mean involuntary movement. So because basal ganglia actually prevent from the involuntary movements. Okay, and if the lesion is in the cerebellum, so what is the main function of the cerebellum? Maintain the posture. Okay, so the patient cannot maintain the posture, mean ataxia. So spasticity, athetosis, and ataxia. So cortex, we also call it the pyramidal tract, and the basal ganglia mean extrapyramidal, and the cerebellar tract. So that's why we name them the pyramidal, the cerebral palsy, the extrapyramidal cerebral palsy, and the cerebellar palsy, and the other is a mixed form. Okay, in the pyramidal, the presentation is the spastic, and in the extrapyramidal, mean in the basal ganglia involved. So dyskinetic form movements mean involuntary movement. Okay, or athetosis, and in the cerebellar there is ataxia. Okay, but the most common type is the pyramidal, where you see the lesion of the cortex, spastic form. So there are different type of the spasticity. If you look at here, so hemiplegia mean the two limbs of same side are involved. Okay, and in the quadriplegia are four limbs are involved. While the diplegia also the four limbs are involved. Not two, do not confuse it. So four limbs are involved, but the upper limbs are less affected as compared to the lower limbs. So lower limbs are more affected. Okay, while in the quadriplegia, the R4 limbs are equally involved. In the athetosis, where you can see the basal ganglia involvement, okay, where you see the involuntary type of the movements in the limbs. If you look at the brain lesion in the hemiplegia, always contralateral side is affected. So if the left side presentation, so the affected side is on the right side. While in the quadriplegia, both sides are affected. In the diplegia, you can see the central area is affected. Okay, here you can see the quadriplegia, all four limbs involved. In the diplegia, lower limbs are more affected. In the hemiplegia, one side is affected. In the triplegia, three limbs are involved. Okay, while in the monoplegia only one limb is involved. So these are different types of the spastic, or you can say the pyramidal lesion. So hemiplegia, diplegia, and the asymmetric diplegia mean not equally affected. Okay, triplegia, three limbs are involved. In the quadriplegia, four limbs are involved. Here you can see the scissoring gait, where the patient lower limbs are just like a scissor. Okay, so which is present in the spastic quadriplegia. And you see they also observe the spastic limbs and the exaggerated tendon reflex. And you see the ankle clonus. Ankle clonus is what when you flex the patient foot one time, and it's followed by involuntary the up and down movement of the foot. So that is a positive ankle clonus. Okay, so these are the different sign of the spastic quadriplegia. And here you can see the hemiplegia. Spastic hemiplegia mean the one side is affected, where you see the affected upper limb and the affected lower limb, where you can see the contracture of the hip, knee, and foot. On this side, you can see the spastic diplegia, where you can see the lower limb is more affected as compared to the upper limb, and you will appreciate the talipes echinovarus, which is a club foot, where you see the dorsum of foot is not normally placed on the ground. It is toward the inward, downward, and the inward. Okay, so it's a club foot. Although these lesions are the permanent, but we should try to improve the quality of life because it's a not progressive lesions. Okay, so it's a static, whatever is happened, it's not reversible. So what we can do, we give some the supportive measures, okay, to improve his quality of life. Okay, so here you can see we are trying to help the patient. Okay, and here I am trying to patient walk. Okay, here is the summary of the types: pyramidal, which is spastic type, and where you see the hemiplegia, diplegia, quadriplegia, and the extrapyramidal, which is dyskinetic, I mean involuntary, and the cerebral, which is ataxia, and the mixed form. Okay, in the etiology, although the most common is the perinatal causes, but you consider the natal as well as the postnatal causes, which contribute 10% oral, 10% natal, 10% the postnatal causes. Okay, but the important thing, whatever the cause, they affect the brain. Okay, so when you go for the CT scan and MRI, you see the different pictures of the brain. Okay, so and also the different presentation associated with that. Okay, so for example, here you can see the cerebral ischemia, and here you can see the cerebral atrophy. I mean the you can see the cortex is the atrophied. Okay, and here is you can see appreciate the different the system multicystic encephalomalacia, and here is the basal ganglia agenesis. So these are all due to different prenatal, natal, as well as the postnatal causes. Okay, so in short, so the motor types: spastic, ethitide, ataxic, mixed. If you look at the associated impairment, you see the sleep disorder, behavior disorder, the intellectual impairment, visual impairment, breathing difficulties, and the saliva control problem, bladder control problem, unable to talk due to the speech motor muscles. Okay, and the unable to walk due to limbs involvement, and epilepsy, mean the recurrent attack of the seizures. Okay, so these are different presentation of the cerebral palsy according to the severity. Okay, in this picture you can see different the cerebral palsy patients. Okay, this is normal. Here is the floppy baby, and here is the stiff baby, and here you can see the scissoring. Okay, here you can see different stiff babies. Okay, and here you can see the ataxia, or you can say gait due to cerebral lesion, poor balance. So this is a test for ataxia. Okay, where you see the attention tremor. Although I have discussed the most important aspect of the cerebral palsy, just convert into text. Okay, and the definition: the permanent static brain lesion during the brain development, which affect the motor as well as the posture. Okay, and in the incidence, you can see the 7 out of the 1,000 are affected by the cerebral palsy. Okay, and the presentation, where you see the delayed motor milestones and the abnormal tone in the infancy, mean the due to upper motor neuron lesion, and their absence and the persistence of the neonatal primitive reflex, because there is age for the neonatal primitive reflex. After that, they are subside. Okay, but in the cerebral palsy, so sometimes some reflexes are the absent, or some are the persist for the longer period. Okay, and you see the abnormal gait in the cerebral lesions. Okay, and there is feeding difficulty, and other depend upon the types of the cerebral palsy. Okay, here is the mnemonic posture to help out the clinical presentation of the cerebral palsy. For example, posture problem, oropharyngeal problem, and speech problem, or the strabismus or second you see in the visual problem, or the tone, hypotonia, or the evolution of the male development, meaning the motor milestone are affected, and the reflexes increase, deep tender reflexes, mean upper motor neural lesion. So 4 to 6 abnormalities strongly suggest the cerebral palsy. Okay, If you look at the motor milestone, so this is the age. These are the different milestones that should be achieved by this age. If they are not achieved by this age, we consider these are there is a delayed milestone, especially the motor milestone. For example, visual fixation by 2 month, vocalization by 6 month. Someone the patient should uh, speak by 6 month. Okay. uh, and not sitting without support by 9 to 10 months, not standing alone by 16 months, not walking alone by 18 months, no single word by 18 months, lack of the imaginative lack of imaginative play by 3 years, loss of comprehension, or the single word or phrase at any age. Okay, so these are different milestones. So we observe in the cerebral palsy. Okay, and if you look at the primitive reflexes, here are different the neonatal primitive reflexes. Primitive mean by birth. So, but there is a age for these reflexes should disappear. For example, rooting when you touch the cheek, so the child try to open his mouth and search that the stimulus. Okay, and in the suckling, when you give finger or the nipple toward the mouth, so he start the suckling. In the morus, when there is extension of the head, so the patient the upper limbs look like C-shaped or the extended. Okay, asymmetric tonic neck. I mean, when the child turn his head one side, so same side the limbs are also extend, but the other side the limbs flexed. Okay, and in the palmar grasp, when you give finger or something in front of his hand, so he try to grasp. Okay, so this is palmar grasp, and this is the plantar grasp. I mean, when you touch the or put the pressure over the bottom of the foot, he try to grasp. Okay, and the Babinski sign is also positive. Okay, so I mean, when you stroke the lateral side of the sole, so there is the hyper extension of the toes. And the stepping, I mean, when you ground is 1 foot, he try to step forward, so by trying to put his second foot. Okay, so this is common in the early 2 month. Okay, trunk incurvation, where you see if you hold with one hand and try to stroke your finger 1 centimeter away from the midline, so the child supine should move toward that side. Okay, so this is the trunk incurvation. The lendo reflex, I mean, when you suspend the baby and his head is lift up and the spine is straightened. Okay, paracute reflex, when you suspend the baby prone and slowly lower the head toward the surface. Okay, the arm and leg will extend. This is the protective action of the baby. So this is continuous throughout the life. Start from the 8 month. This is summary of different the neonatal primitive reflexes, and this is the duration. Okay, why it is important? Because these reflexes are associated with the different part of the CNS. Okay, so if that reflex is absent or the persistence, mean the lesion is associated with that area. In the etiology, as I mentioned, the most common is the prenatal, mean 80% cases are there are some prenatal causes like malform CNS or the intrauterine infection or ischemia or teratogen. So there is a long list of the prenatal causes. Okay, and in the natal 10%, but the most important is the prematurity, low birth weight, and asphyxia. So these are the very important risk factor, because if these risk factors are present, so the risk of the cerebral palsy increases many times. Okay, so and anorexia, hypoglycemia, although these are the causes of the cerebral palsy, but the most important risk factor is the prematurity, low birth weight, or asphyxia. Okay, in the postnatal, if there is infection, trauma, toxin, or any vascular event which occur, so this can lead to the some brain lesion, so which cause the cerebral palsy. The types, the physiological types are the spastic, athetide, ataxic, atonic, mixed, and the topographic, we name them the mono, hemi, quadri, or di, and triplegia. Okay, and there is also a functional classification, or you can say functional types. We look at the activity, or you can say the limitation of the activity. We look at the no limitation, mild limitation, or the severe limitation in the activity, and the last stage is the no physical activity at all. Okay, and the site of lesion, you know better, pyramidal, extrapyramidal, and the cerebellar. Okay, in the spastic upper motor neuron lesion sign, and the athetide, where you see the abnormal and the involuntary movement, ataxic mean tremor, and the imbalance, atonic mean false and the symptoms. Okay, and there is a mixed type also. In the topographic, the mono one limb, hemi two ipsilateral, quadri four limbs, di the all four, but the lower are more affected as compared to the upper, and tri mean three limbs are involved. Okay, so these are the pyramidal types, and in the extrapyramidal, spastic and athetide. In the cerebellar, there is ataxic and the atonic types. Okay. If you look at the pathology, we are looking at the brain picture, but we find in the severe cases, we see the cerebral atrophy plus the subcortical, the cavity formation. Okay, so here you can see the cerebral atrophy. In the extrapyramidal palsy, you will see the basal ganglia, the lesion like atrophy or agenesis. Okay, and if in the hemiplegia, you see the opposite cerebral atrophy and the gliosis. Okay, especially this associated with the intrauterine stroke. Here you can see the cerebral ischemia. In the diplegia, we see the periventricular leukomalacia, where you see the periventricular densities which are greater than 3 millimeter. They involve in the cyst formation. So this is the periventricular leukomalacia. Okay, and in the quadriplegia, you see that these are the severe periventricular leukomalacia plus the multicystic cortical encephalomalacia. Okay. And this is quadriplegia is mostly associated with the birth asphyxia. And here you can see the multicystic encephalomalacia. Okay, and you can see these are this is the ventricle. Okay, and here you can see the different cyst formation, which are periventricular leukomalacia. Okay, here you can see the ventricular, and here is the periventricular, the white area. This is show the damage of the brain. Okay, so periventricular leukomalacia. Okay, and the cystic encephalomalacia. And here you can see the also the severe form, where you can see the ventricular and the surrounded by this white area, the periventricular leukomalacia. Okay, this is a diagnostic criteria. You know better. In investigation, you start with the history and the examination of the patient. Okay, and you assess especially the visual and the hair function, because the visual and the hearing function are mostly affected in the cerebral palsy. Okay, and you go for the ultrasound if there is early neonate presentation, and go for the MRI if there is a older infant. Okay, and also go for the EEG. You check the brain activity, and we need to do the metabolic screen to assess the any metabolic abnormality which is contributing toward the cerebral palsy. Okay. In the management, there is teamwork needed, because we know this is a permanent lesion. We are trying to improve the patient quality of life. Okay, so we need in the team pediatrician, physiotherapist, psychotherapist, and the orthopedician, speech, social occupation therapist. Okay, in the medically, we try to give the antispasmodic, diazepam and baclofen to decrease the spasm, and we give the anticonvulsant to prevent from seizures. We give the anticholinergic if there is a rigidity or and soluria mean the hypersalivation or the excessive drooling. Okay, and in the surgical management, orthopedic is needed if there is scoliosis or the contracture, and the neurosurgery if there is a spasm. Okay, and aim is to improve the function, prevent deformity, and encourage the independence. Okay, this is all about the cerebral palsy. These are pictures we already discussed. Thank you very much. Allah Hafiz.